Thank you, Ms. Amin. Bismillahirrahmanirrahim. I will begin my talk about the demographic risk factors of older adults in Pakistan and how it helps to achieve sustainable development goals. As we all know, that in this life course, increased age is associated with the specific pattern of mental disorders. But here, it is important to know how demographic factors such as ethnicity, age, gender, and sex has become the risk factors of developing mental health disorders among older adults. Although it is thought to be as a protective factor, such as when you get older, you become wiser, and how we can prevent it while directly achieving the Sustainable Development Goal 3, which is good health and well-being, and the other Sustainable Development Goal 5, which is about gender equality. We have started to do a systematic review on the domain of older adults. We are focusing on demographic risk factors along with the potential effective interventions. Next, please. In this process, we run search strategy and found 158 total screenings in which 143 articles were excluded at the stage of title and abstract screenings. Total 15 articles were mainly related to the demographic risk factors and potential interventions of older adults, which is again related to demographic factors. The excluded articles were mainly not related to Pakistan. Some are duplicate studies, some were focused on qualitative research methodology, which is basically our exclusion criteria of systematic review. Next, please. Here is the main findings in which we found that 13 studies were mainly related to the risk factors of developing depression among older adults, in which 3 studies showed that being woman is a risk factor in older age for developing depression. The result of other 3 studies also showed that being single or not living with spouse is also a risk factor of developing depression. Plus, increasing age is itself a risk factor of depression, which has been proven in 7 studies of Pakistan. Furthermore, one study also showed about the death anxiety, which is more found in unmarried elderly instead of widows or married elderly population. Now, the last and very important finding is about executive dysfunction, functioning, in which it reveals that gender, marital status, and functional formal education are associated with cognitive, emotional, and behavior difficulties. Thank you. Thank you, Ms. Ami. Thank you all.
Thank you, Maham. Professor Mowaddat Rana, I would now request you to please chair the discussion session for this particular domain, sir. Sir, I would request you to please unmute your mic. Thank you, sir.
Bismillahirrahmanirrahim. Thank you very much for asking me to chair this session. I'm particularly grateful to Mr. Riaz Fatana, who's a constant source of inspiration and support for all of us as mental health professionals, but also look up to him in his capacity as a legislator in Pakistan with a deep interest in mental health services of the country. His support in the last 2 years in particular through the forum of PIL has been even more inspirational. And to follow up on the initiative that started the presidency last year shows that he's been earlier part of the year shows that he's following up on his commitment with the mental health services in Pakistan and their development, as well as on making it into a policy issue around the country. Now, the couple of points that I particularly expect our discussants to focus on are based on 2 observations as a mental health professional engaged in the not only at the forum of Alzheimer's Pakistan, but as a practitioner at a clinical level and looking at old age patients and their families. The first is that we are primarily a country or a culture which has a deep commitment and intent towards taking care of our elderly. As a culture, both in terms of thousands of years of the Indus Valley civilization that we belong to, and the Islamic culture that prevails in Pakistan. At both those levels, the intent to take care of our elderly is huge and has been traditionally present all through. Yet, the services that are provided by the families primarily are not recognized, number one. Two, these services are never researched. And three, that it is provided by people with tremendous positivity and intent, but hardly any training in how to look after a person with challenges of the old age, particularly if the dementia has set in. So if we can start by discussing these gaps, that the intent is there, the institutional commitment of the family is there, there's a huge tradition of care that is available to us, but the gap that exists in terms of training. Second is that there are large number of evidence-based interventions now available from around the world. But those interventions, since there's no training of the people who are looking after their elderly primarily at a personal level, there is a disconnect between those scientific materials that are available in terms of provision of care, not reaching to the families. So it's scientists who are engaged in dementia care talking to each other. So we are preaching the choir all the time. So their wonderful ideas are not reaching the people who can really consume and look after. That's a very Western model, because there, of course, the mental health professionals engaged in dementia care can reach to the old age homes, the hospitals, the hospices, etc., etc. But families are who are looking after the elderly are unreached populations. So wonderful interventions, scientific data, but not reaching the family. Those are two major challenges that I'd recommend that we talk about in our discussion from here on. Over to the discussants. G, please. Our discussants really to now take it from here on and give their thoughts and ideas.
How do we go about? I'm a panelist, so I'm remaining quiet. I thought somebody else takes the lead, or if people don't, then I can always speak up.
Anyone who's got any suggestions and ideas on what Professor Mowaddat has suggested is free to sort of raise their hand and share their thoughts.
Okay, I've already raised my hand. I'll be very short because I've seen the timetable. I think it's a short, and I would want the others to contribute more. But I think Professor Mowaddat is absolutely right. Most of the researches, when we start exploring, are being done by clinicians, and they have a clinical mindset. So if you look into most of those studies, you would find very few coming from the community. And that's what Professor Mowaddat is stressing, that when we work into academic institutions and tertiary care hospitals, we are providing the help, or we are providing the awareness to a very small section, because they're the ones who are coming to us. What about those who are in the community and not being looked after? The other aspect is that if you look at your life cycle approach, we have huge investments into the child and adolescent mental health. The adults we are already engaged with, so we're putting a lot of effort. But when it comes to the elderly, and I don't use the word of older, I use the word of elderly mental health, the population would not like to invest, because they think that this possibly is a population who may not be of any use to them. It's a blessing that we have a culture that we are looking after our parents. But then now in our structure also, the culture is changing. When people come, and once I've seen the elderly father or the mother, the family comes into my room and they're saying, do you have a capacity to keep them in your hospital? And I tell them, look, this is an acute unit. I would provide you our facilities in the community. And then they come back and they say, okay, Dr. Shah, what? We do not have any facilities in the community. I know we have got Alzheimer's Pakistan on board with us. We give them those booklets, we give them everything, but still I believe there's a huge, huge scarcity. The services that should be provided to the people, to the common people, knowing about what problems can occur in the elderly in the community, are still lacking. I think our strategies have to be devised accordingly, not just based on institutions and not just based on academic institutions or tertiary care hospitals. So I would like the others to give their viewpoint too. Thank you.
May I request Professor Erisima Leroy, she's been the architect of the roadmap for dementia, particularly from Pakistani perspective, and has been a true soldier working alongside us on this issue, to throw some light and her ideas on the themes that we've been identifying in this discussion. Professor Leroy.
Thanks very much, Professor Rana. I'm honored to be here, and thank you for calling on me. Yes, I'm listening to this. It's going through my mind the kinds of themes that came out of our roadmap, which I hope to touch on at the end of this forum. And I think some of the key issues are, number one, that the solutions have to be appropriate to the local context. However, that doesn't mean, I don't think, reinventing the wheel entirely from scratch. I don't think there's time to do that. That would take 25 years. So it's about taking the learnings from overseas, where older adult care, particularly for mental health, has progressed quite well, and adapting those, and I think accelerating the trajectory from proof of principle to implementation. So if we go back to the very beginning and start reinventing everything from scratch, I think it'll take too long. So what that really means is looking around, exactly like we're doing in this forum, what is the best evidence from elsewhere, but then adapting it and seeing how it can be used here. And I think in our research roadmap, we try to address that by saying that when we bring ideas from overseas, things that have worked, things that have a good evidence base, we have to integrate them and involve people on the ground. And by that, I don't mean clinicians and researchers, exactly as the point was made, but the people living with the condition, carers, through the process of patient and public involvement, to understand how will this work in this context, and then move fairly rapidly from feasibility and adaptation into implementation. And I think that's one of the keys, is that the focus on implementation research needs to be brought in here. How will this thing work in its adapted version in the current context? And that's a big challenge, not just here, but everywhere.
Thank you very much, Professor Leroy, for identifying. If I may just add and ask for a supplementary comment from you, I can assure you that the models of care that families in Pakistan use in the care of their elderly are sometimes most innovative and interesting, actually. So I personally believe that while we can learn a lot from the West in terms of flow of data and information coming from there, in terms of evidence base, in terms of methods, newer techniques that have come in, including medication and all the rest of it, Pakistan and South Asia in general has a lot to share with the rest of the world in terms of a bilateral flow. And this roadmap that we're talking about, once this road is made, Pakistan is making all kinds of roads these days, particularly with China. But you know, in this particular kind of road that we are planning, it will be a bilateral flow, and there's a lot that that we can show to the West. It's just that our practices and our interventions and the methods that are used so innovatively with minimal resources, absolutely minimal resources by families, can serve as possible models for the West as well. So that's a kind of a thought that I'd request Mr. Hussain Jafri from Alzheimer's Pakistan to say a few words on that, followed by our president of Alzheimer's Pakistan Chapter, Brigadier Rana. Over to you, Jafri Saab.
Thank you, Professor Rana. I'm grateful for the opportunity. I think I'll start with the training that you discussed earlier on. That I think there's an issue with the training program, and what we as family caregivers have also experienced, that there is a problem of diagnosis, with the lack of understanding at the level of the healthcare providers. And somehow the other, I think the dementia has been categorized as a medicalized sort of a problem, where we have very little medical help that we can provide to the person with dementia. So I think we need to take that out, and we need to understand the sort of the solutions that are possible to provide relief to the family as well as to the person with dementia. Then the training, as you said, there's another issue with the training of the care providers, because as majority of the doctors do not really understand dementia, the families, they have really no idea what dementia is and how to look after a person with dementia, and since they don't have an idea, I think we experience a lot of psychosocial and family problems because of those issues, because then these people with dementia then categorized as mad people and all that sort of stuff. Then I think there's another issue of society as a whole. There's a mindset, when we start, we provide the service of like daycare center, then, there is still, although we have started this service about more than 10 years ago, but there's still a different mindset in the society whereby the carers, one of them would say, well, it is my job and nobody else can look after him, and I should be the one doing this caregiving myself. And then there is other mindset that what is going to be said by other people, that we send them to a daycare center or something, and so we can't look after our loved one. So I think there is a lot that needs to be done at the level of the community as well, for creating awareness about these issues and what sort of services. And as previously been I think said by somebody, perhaps it's about the neglect of the family. I think that's also another issue, because once there are no formalized services available, then if in our society, many of these people with dementia are also neglected by the family. So we need to have a program whereby we can create understanding about disease and awareness about the disease. So considering this, as WHO has about 2 years ago, they come up with national dementia plans. Following up on that, we have developed a national dementia policy draft that even Professor Larai has given her input into that. That is ready. We have already discussed this with the government of Punjab. The health department is ready for that. I've also discussed it with Dr. Faisal Sultan at the federal level. So it was ready by at the beginning of this year, but because of COVID, it all stopped. But now I think
I'm really sorry, sir. We are conscious of time. If you could just keep it a bit short, and maybe
I'm just wrapping up.
I'm really sorry, sir. My apologies.
No, it's okay. So that policy is already there. So hopefully, very soon, either we'll get it launched by the federal government, by the president or somebody. So if there is some delay at that time, we will get it launched by the provincial government. The provincial health department has already given its blessing that they will have a complete PC1 on that. So that's a big progress as far as the dementia is concerned. Thank you for the opportunity.
Thank you so much, Mr.
Could we request Navar to add anything else that he would like to, as the president of the Untitled Chapter for Alzheimer's Pakistan? Brigadier Munawar, are you there?
Mowaddat, Professor Asghar Zaidi also wanted to comment.
Ji, please, Professor. Most welcome.
Ji, thank you so much. I think most of the things that I wish to raise have already been mentioned by Leroy and Hussain Jaffrey. But one or two things, and this is coming from a very rigorous research we did with Alzheimer's research, with the help of Alzheimer's research, and in which we interviewed the patients with mild dementia. We interviewed their caregivers. We had focus group discussion with the community persons, and we also had interviews with the key stakeholders. Two things that stood out. One of the biggest stress factor for patients as well as for caregivers has been that they were unaware of the fact that people with mental disorders were exempted from religious duties. And I think that's where the interventions are necessary, either from Alzheimer's Pakistan or from other such national level organizations that can raise awareness. Then, Dr. Rana, you raised a very relevant point that we keep talking amongst the converts, and we need to go beyond. And one of the models that I was discussing with Hussain Jafri is that to provide information and equip them and train lady health workers who often go house to house, perhaps for a different reason, but they can also keep an eye to see if there is an elderly in the family, and awareness could be raised. One last point, and I know I wanted to be brief, but one last point. There is often a monopoly amongst the GPs that they don't let the patients go to the secondary or tertiary care. And they just hold on to the patient saying, oh, well, this happens when you get older. And the same people, even at the early stages of the onset of dementia, they are not referred to any secondary or tertiary care. And that leads to the fact that often they come in contact with tertiary care when it's almost too late. So something needs to be done at that level as well. The GPs are trained so that they could pass on to specialized care any patients that they come into contact, especially those who have mild early onset of dementia.
Thank you very much. That's most useful, Professor. We are very lucky to have legislators in our ranks today. And so I was wondering if any of our legislators, health being a provincial subject now, largely in most of its domains, would like to comment and how